Good afternoon, everyone. I'm in the sunny, warm section of the country, and I hope those in the blizzard section of the country are warm and safe. Welcome to the 8th webinar in the HHEAR Exposomics webinar series. Exposomics is a rapidly evolving approach in biomedical sciences. It involves characterizing the totality of exposures and their effects on our health from conception throughout the life course. HHEAR is hosting this series of webinars on various topics important to exposomics. All the webinars will be recorded and made publicly available on their website, HHEARprogram.org. I am the moderator for today. My name is Susan Lessig. I am a toxicologist and program officer with the ECHO program, the Environmental Influences on Child Health Outcomes program in NIH Office of the Director. I was asked to moderate. ECHO's goal is related to exposomics in that we seek to answer solution-oriented questions about the effects of a broad range of environmental exposures on child health and development. ECHO works closely with HHEAR investigators to characterize exposures during pregnancy and early childhood, and then look at impacts on later health outcomes. So today we have a wonderful webinar on advances in statistical methods for exposomics. Because exposomics captures multiple exposures simultaneously, we want to study the combined burden of these exposures on their biological pathways, and we need some advanced statistical methods for this. We will hear today from Dr. Chris Jennings and Dr. Christy Avery, two wonderful speakers who will speak about advances in chemical mixture analysis and causal inference approaches for exposomics research. So without further ado, I'll introduce Dr. Chris Jennings, who is Director of the Division of Biostatistics and Research Professor in the Department of Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai. She also holds a secondary appointment as research professor in the Department of Population Health Science and Policy. So take it away, Chris, with your talk. Looking forward to it.
Thank you very much. Let me share my screen. Okay. Okay, I appreciate the opportunity to speak at this webinar today, and I appreciate the invitation. So let me just forward along. So as Susan described, I'm going to try to get this out of the way. The exposome is a holistic view of human health and disease. It includes things from exposures. It could be diet related, it could be lifestyles, it could be consumer products, all kinds of different things. But what I'm focusing on is sort of the good and the bad, the advantage of nutritious eating in terms of human health exposures, but also recognizing that we're exposed to so many chemicals that could have adverse effects. So I'm going to be focusing on a nutrition index that we've developed first, and then I'll talk about a method for looking at environmental exposures in terms of measuring a mixture effect. So the idea is to have, like I say, the good and the bad together, the benefit of good nutrition with the potential of adverse effects from environmental exposures. And of course, it would be fabulous to be able to evaluate sort of the balance between those, and more particularly if good nutrition could actually mitigate the effect of the adverse exposures that maybe a particular person may not be able to do much about. Okay, let's see. So, okay, there we go. So one way of thinking about nutrition is based on a food-based approach, eating patterns and or mixtures of foods. The Healthy Eating Index is one such example of an index. that you see here, you may be able to see in the green that it's based on, adequacy values as well as moderation values. But it's actually an index that can be used at various places in the food stream. So it could be based on, evaluating a community food environment or fast food menu, or it could also be a measure of individual food intakes. But I'm more interested in something that's more specific to individual subjects. So we're asking the question, what's right for me? And so we are thinking about personalized nutrition, which has to do with, your characteristics, your age, your height, your weight, your sex, your activity level. Do you smoke? Do you drink? Are you pregnant? Do you have some kind of a medical condition? These are all things that are very personal. So it makes sense to say that, there is no one size fits all diet. The perfect diet for one person may be very different for another. So we've developed something called My Nutrition Index, and we called it My Nutrition Index because of that idea of saying this is a personalized index. So the My Nutrition Index, or MNI, incorporates dozens of macro and micronutrients. And like I say, it is based on subject-specific characteristics, which could be health-based as well. We're working with an IBD clinic dietitian, and people that have irritable bowel disease, have incremental changes based on the disease, then that might change their dietary requirements. So these are kinds of things that the My Nutrition Index can address. So, for example, we think about the Mediterranean diet as, a healthful diet. I found a published version of the diet. You see here on the table, just a list of components that might be in a Mediterranean diet. And you see, it's got the seeds and the grains and the beans and the, oils and things. So you might think, well, that's going to be a good diet. So based on the My Nutrition Index, a young man, moderately active, average age, that would be a good diet with a My Nutrition Index of 95. So the index goes from 0 to 100, where 100 would be, absolutely perfect, and nobody eats like that. A middle-aged woman, however, who's much smaller and maybe not so active, the My Nutrition Index would calculate that at a 69. So it's the same diet, the same components, but not as good for that woman. But if that same middle-aged woman has, a chronic health condition and needs a low-fat diet, then it's even worse. And it's a complicated thing because, the bottom line is that diet has too many calories and carbs, too much sodium and total fat, and not enough vitamin D. So recognizing that about your diet might be hard to figure out, well, what am I going to do to fix that? So that's sort of the way that we're trying to address this My Nutrition Index. So the My Nutrition Index can be calculated from a dietary recall. It can be calculated from food frequency questionnaire data. And we're working on a dietary tracking app. Right now, the My Nutrition Index, we have a web-based app for researchers where if you have nutrition or nutrients from diets on your subjects, you can calculate the My Nutrition Index, and I'm happy to share a link and things with that. And we're right now at the place where we're working on an app for tracking of foods, but we're at the early days of that. We're kind of beta testing that right now. So that's the My Nutrition Index in a snap. But the question is back to the research question of, well, what does that mean in terms of human health and in terms of, relative to environmental exposures? So this is a paper that we published a couple years ago. This is prenatal exposure to chemicals, but also mid-pregnancy food frequency questionnaire data that we calculated the My Nutrition Index on. So you see the distribution here of the My Nutrition Index. This is the Selma pregnancy cohort in Sweden, and they have 7-year IQ of the children. But the figure on the right is what I really want you to think about, is this concept of, the benefit of good nutrition compared to the, adverse effect of environmental exposures, early prenatal, it was first trimester exposure. So this is the log scale of bisphenol F, and you see that so this is 7-year IQ, we see that there's a decrease in as bisphenol F increases, we see there's an association to IQ that decreases, but on the other side, the My Nutrition Index increases. These are calculated based on the other covariates being centered and scaled, so it's a little bit more interpretable, the values there. And we see that we have significant associations in both directions, and that's the point, is for people to try to think about, you know, I might not be able to do much about my environmental chemicals or exposures, but I maybe can do a better job of eating. And this is where we might see the benefit of that. But of course, what we have is not just exposure to a single chemical. We have exposures, you know, that it's like an onslaught, right? All these different products and consumer products and that have an impact on our that may have an impact on our health. So what we want to do now is to address the dimensionality of the exposures as well. So we've got the nutrition, the My Nutrition Index and other indices, but we're focusing on the My Nutrition Index that might account for the benefit of good dietary, you know, quality. But what about the adverse effects of the chemicals? And so what we're going to focus on is the concept of finding a weighted index that measures the mixture effect of these chemicals. So there's many chemicals that we're exposed to, but is there a mixture effect? And by a mixture effect, what I mean is as chemicals are acting, jointly acting, they're acting in a similar way, you know, across some adverse outcome pathway or whatever, but that might have an impact on the same health effects, then by accounting for them together, that's what we say is the mixture effect. It's not just one chemical at a time, but it's the fact that they're working sort of in concert together to potentially impact health. So we're doing something called the weighted quantile sum regression with repeated holdout. So this is a little schematic to try to describe to you about the weighted quantile sum regression. So the first step of WQS regression is we have multiple chemicals where we put in the same scale. We quantile them so that we can interpret a weighted index. The weights can be interpreted if the exposures are all on the same scale. So we quantile them. It could be deciles, quartiles, whatever you choose. But on the left-hand side here, the first thing we have would be, if we have individuals, we're going to randomly split them into what we call a training set and a testing set. The training set is where we estimate the weights for our weighted index. And then once we calculate that index, then we come over and test for the significance of that in the holdout data set. The weighted quantile sum index, I'm not going to go too much into this, but we have what's called an ensemble step where we're training based on that. So we can randomly select people with replacement and do that multiple times in different samples, and then combine across those to get average weights. Or if we have metabolomics or other sort of analyses where the number of chemicals or the number of components exceeds the sample size, then we can do a random subset of the selection of those components. So we can allow for both when the number of components is bigger than the sample size and when the number of components is less than the sample size. But either way, we get a weighted index at the end. But what we want to do also, though, is then say, you know, we've got this single training and testing partition, but we want to do that many times. So this repeated holdout validation step has started to become really useful, I think, where we do this splitting multiple times, say 100 times. And by doing that, what we see is the distribution of the weights and the distribution of the beta coefficients that we have at the end of the day after we do these repeated holdout validations. And that's because every time you split the data, you have a slightly different, you know, sample of characteristics that you're basing things on the training part and on the testing part. So we want to see that distribution. So that's what I'm going to show you today in several different examples. So we'll start by going back to the Selma cohort. And so the Selma cohort, again, is this, it's in Sweden. It's a prenatal exposures and diet, and we're looking at health effects in that. So this one, again, is back to the 7-year IQ. What you're seeing here on the divergent plot is the results of 100 repeated holdouts, like I just described, where we're allowing for different weights on the components and different beta coefficients for each sex. And what you see in the divergent plot is the mean estimates from those 100 repeated holdout validations, the mean estimates of the weights. And so you're seeing the green or blue, whatever color that is, for the boys, but that's not negative. That's just, I'm just comparing the two. So there's positive weights here, right? So, but you see that there's a little bit different impact of bisphenol F. It's a little stronger in boys than it is in girls. And you can compare that also to DPHP, where it's more of a important in girls and not so in boys. And I should point out this dashed line here is actually the equi-weighted value that we use as sort of a cut point for interpreting. So we say if the weights are higher than the equal weights for the number of components, then we say then that's a signal that we want to look at in terms of the importance of that component. So you can see that, you know, the set that you might have for girls is going to be different than for boys, and that's the whole point. What we see up here in the top right-hand side, though, is the confidence intervals on the betas that are standardized from these 100 different repeated holdouts. And so what you see in the blue here is the confidence interval for the boys, which does not include 0, but the confidence interval for the girls does include 0. So we say that we have a stronger association. It's more of a boy thing than a girl thing, right? In terms of the impact of these endocrine disrupting chemicals on the brain development, potentially for IQ. But sitting next to that, or sort of on the other side of that, is the My Nutrition Index. And here's the index with these different holdout data sets, and you see the confidence interval for that as well, but now it still is positive. So we see this countering again, which is really interesting, I think. And that's the point of putting these together, the exposures and the nutrition. This little figure at the bottom is, it's each sort of column here is an individual in the study. And what you see is that humans, these women were exposed to chemicals from multiple chemical classes, so the phenols, the plasticizers, other short-lived and persistent chemicals. So it's really, exposures are really complex in the sense of it's not just, you know, the plasticizers that are a problem. It's a bunch of different components. And this is to point out that these are chemicals that all of those women were exposed to, you know, 100% detect. Okay, so now that was the study, the Selma, that I highlighted because of the My Nutrition Index, and we have food frequency questionnaire data there. We've been doing analyses, you know, in the HHEAR and HHEAR data center. And so I'm going to present this here, but I don't have food frequency questionnaire data yet in here. So this part of the talk is really just focused on exposures and not on the nutrition. But this is a study, it's a cross-sectional study from Charge. Debbie Bennett's paper is what I highlight here. And this was cross-sectional case control design. We have autism, developmental delay, other early concerns. These children were diagnosed at age, I think 2 to 6, 2 to 5, something like that, versus typically developing. You see the sample sizes there. So what you see here is, I'm presenting it a slight bit different. This is as in that the Bennett et al. Paper, which came out in 2022, I think. But here's autism, and you see the betas, the odds ratios for the autism compared to typically develop is positive. It's above 1, meaning that there is an increased risk of autism based on these exposures. And the covariates that were adjusted for are listed down here. And so I just here, although we've done this multinomial analysis here, I'm focusing here just on the autism versus typically developing. But what you see are these are the distribution of each of the weights of these different chemicals, pesticides, phthalates, phenols, and trace elements that that were estimated across these 100 repeated holdouts. So we in this paper, we actually published what we're calling now the Busgain criteria for association. So where the idea is that if you do this repeated holdouts and 100 times, and more than 90% of those times, like here for DEP, end up being above that threshold, then that's what we would say is a probable association to that outcome. But instead, if it's somewhere between 50 and 90% above the threshold, then maybe we say that's a possible association. And we can do the same thing on the other side, where we have, it's probably or possibly not related. So this is just a concept of the variability in the weights as we cut the data separately, in different holdouts. And you see that we have a significant association, and we can interpret the components like that. Here's another study that's not yet published, Elizabeth Jensen's study at Wake Forest. And this is based on the SEARCH data set, or study that's focused on diabetes in children, onset diabetes in children, and the potential for cardiovascular health effects at the end. And so this is just sort of a little study diagram of, the kids come in at a baseline, and then, but what we're focusing on is an outcome later on where we have measurements of diabetes related, or we're going to focus on cardiovascular outcomes. So what I'm just going to show you kind of quickly is where we have preliminary data at baseline, and then the follow-up where we have this cardiovascular disease associated risk factors. So we have a bunch of these factors here that were measured at follow-up: waist to height ratio, triglycerides, LDL, HDL, et cetera. We took the continuous variables there and that put them in the same direction. So we had to, inverse the HDL, but and we created a principal component, the first principal component of all of these. The arterial stiffness we didn't include because it's a yes/no, but we took the continuous variables there and created a principal component that is like a cardiovascular disease principal component. And that's what we use for the outcome. So that was at the follow-up. And what I'm going to show you here is that repeated holdout analysis. Again, in the metabolomics data, we have the positive HEAR mode and then the reverse negative phase, I think is what it's called, direction. So this is just one of the examples. There's a whole lot of data analyses that are here, but this is just one example. Again, with the repeated holdouts, the WQS index is positive. The 0 is down here, so that there is an association there with these metabolomic. And so this is the baseline metabolomic analyses with later, cardiovascular. And I think it was, I don't remember the years, but a handful of years later. And we're looking at the principal component of those cardiovascular disease. So these are children with diabetes. But so that's just one of the outcomes. And here are the weights that we see here. So using the Busgain criteria, we have the probable contributors here, where more than 90% of the weights across those 100 repeated holdouts is above the threshold, and then the possible contributors are the next 4 there that are not quite as strong, but between 50 and 90% are above that cutoff. And this is just a diagram that I think is really kind of cool to see. As you see here, the blue boxes are those that have a positive association, and the orange boxes are in the negative associations. But this is where we have single chemical and WQS regression, and both in the positive mode and in the reverse phase mode. And so, but what you see, regardless of that, there are some things here, like look at uric acid. It's the blue. It's for however you looked at it, it's going to be an association. And some of these where the blue is, sort of across the different, is it a baseline measure of the metabolomics, or is it a follow-up measure, things like that. But there are some consistencies then across this. So like I say, the Jensen team is busy getting ready to publish this, but she gave us permission to, and in fact, these are her slides to present to you all today. So what we're trying to do, just in summary, is to use the My Nutrition Index as a way of measuring the value or the quality of one's diet. And then we can use something like weighted quantile sum regression to measure a mixture effect that allows you to look at higher dimensional exposures, but in terms of a lower dimensional effect, to have more power and things because of the focus of the inference on that mixture effect. And hopefully we're combining then that idea of good nutrition and the potential for the adverse effect of environmental exposures. So a team is what we need. And so I give a lot of acknowledgement to this wonderful team that we work with from the training grant back in the day. At Virginia Commonwealth University is where we started with the weighted quantile sum regression, and it's been extended now with the work that we're doing at the Icahn School of Medicine. Stefano Renzetti is sort of leading the R package part of GWQS, and he's fabulous. If you're running that and have questions, he's open for ideas. And then we've got a lot of people in the data center that are extending and helping to use some of these methods. So it's really a great team to work with. So thank you very much, and I'm happy to try to take some questions.
Thank you very much, Chris. That was a great talk.
Thank you.
Yes, if you have questions, please put them in the Q&A. And there is already one question there, which I will read from Jason Betker, who asks, with the weighted quantile sum regression in the Selma cohort, for instance, how do you separate out the component weights when certain chemicals might co-occur frequently?
Might co-occur frequently.
Might co-occur.
Yeah, so that's the whole idea of the ensemble step in WQS regression, and that is to say, when you have components that are correlated, right, which often is the case in environmental exposures, then when you do any of those analyses where you're trying to choose those that have an effect, you know, in a single realization of the analysis, you might put weights on some of the chemicals in a correlated set. And then if you do another bootstrap step or you do another random component selection, then you in the next sort of realization of that, you might put a little bit more weight on another part of what's in that correlated set. And by doing that many times, that ensemble step, then we're able to take averages of those to kind of get signals from, you know, to kind of get signals from individual components in correlated sets. So that's the idea of the ensemble step, is to try to address or accommodate that complex correlation patterns that we often see in exposures. It's a good question.
Okay, there's one more question from an anonymous attendee. It says, I am wondering about diet and mechanisms of toxicity. Wouldn't different dietary components matter for different exposures? For example, low folate leads to increased chromosome breakage.
Yeah, I mean, you know, there's always the people in science that want to focus on particular things like that. That's not my expertise. I can't go back to, you know, one component and some DNA, this or that. I think that's important work, but I think my contribution is more at a gestalt level. My contribution is going to be more at I don't want to tell you just eat selenium or just do, you know, I want to be more overall, you know, what is general description of how you improve your diet? That's not to say that that's the only way it should be looked at, but that's, I think, an important way of thinking about things to give a positive public health message about dietary intake. Now, you know, there's certainly room for, you know, other ways of looking at things that can also contribute. So I don't, from the approach I take, those kinds of questions I can't address. It's not the focus.
Thank you. I think we'll move on, and if we didn't get to all of the questions, we will circle back after the meeting to answer those. So I would now like to introduce Dr. Christy Avery, our second speaker today, who is Associate Professor of Epidemiology at the University of North Carolina, Chapel Hill, Gilling School of Global Public Health. She will be speaking about strengthening causal inference in exposomics research, application of genetic data and methods. And here come her slides. Go ahead.
think after doing it so many years, I could do this a lot faster. Okay, can everybody, I'm assuming you can see everything?
Looks great.
Oh, okay, awesome. Okay, so let's see here. So I wanted to, so thank you so much for inviting me. This is a fun talk to give. Something definitely near and dear to my heart. And hopefully by the end of this talk, you'll think it could be potentially near and dear to your heart too. So the roadmap I'm going to talk about is I'm going to start with an overview and motivation for the talk, then move through genetic variants, core metrics, and then finally get to the meat of the talk, which is causal inference, and then give you final thoughts. And if you think I'm just using my overview slides to show you some of my favorite memes, you might be right. So the motivation for this talk was the Exposome boot camp that I attended in 2020, maybe 2021. Everything rolls together with COVID. That was offered through Columbia University, which is fantastic if you have not yet taken it. And as a newbie exposomics scientist, if I could call myself that, I got a lot out of the talk or of the boot camp, but I also had a lot of questions in the end, specifically from being asked as a scientist who's an epidemiologist with expertise in genetic epidemiology. And so after thinking about this and talking about the opportunities with some of my colleagues, we ended up writing this commentary, which showed up in EHP last year, that's about the topic that we're at hand today. So in case there's anything that's not clear or you want to read more, that could be a good place for you to start. So specifically, what was the motivation for our commentary or, you know, this talk today? Well, you know, as Chris and others have told you, and you probably know, the exposome is broad, and so there are challenges. And someone once told me, don't use the word challenge, always use the word opportunities. So then opportunities abound. Specifically, you can think as, you know, as an epidemiologist, I think, oh man, this is challenging. You know, you have measurements across a life course, you have the measurements in different populations, and you have the complex correlation structure. And as this was laid out in this Exposomics bootcamp, I thought to myself, you know, genetics could really help clarify some, not all, but some of these concepts, right? So I started digging into the data, and there's this nice paper by Niedzwiecki and Miller that showed up in 2016. And, you know, they were talking about genetics, and they state that, quote, Beyond Disease, the largest meta-analysis of twin studies to date, estimated that across all complex traits, this is the important part, the influences of genetic and environmental factors are nearly equal. And so that's something that I really saw a lot in the research, which was kind of genetic data were often presented as a counter to the exposome. Or if they were presented, it was only in the context of gene-environment interaction studies. And for those of you who've ever read The Ballad of East and West by Rudyard Kipling, it kind of made me think of, you know, that famous quote, "Oh, East is East and West is West, and never the twain should meet." You know, which is kind of interesting because, you know, just like, you know, one person's on one side, one's on the other. But if you read the, you know, the ballad, you'll see that it shows that these two seemingly unharmonious things actually have a lot more similarities that might be that aren't apparent on the surface. So what unique benefits do genetic data offer to help us address these exposomics, there I go with challenges, opportunities? Well, just giving you a 20,000-foot view, germline genetic variants are time invariant. So, and then you can also think, and I'll show you in a bit, how that many exposome exposures or the biomarkers of exposure are heritable. So we have something that's time invariant, and then we have the things that we're interested in that are heritable. I would argue if you see the figure on the right, which is showing genetics in the central part, and then looking at some dimensions potentially of the exposome, for example, the natural inbuilt environment, social environment, chemical environment, and health behaviors. There might be, for some of these measures within each dimension, some role for genetics. And again, I'm not saying everything. Genetic data are also becoming increasingly ubiquitous in that they're being measured and available in a lot of the studies that are near and dear to y'all's hearts. And then finally, the development and application of statistical methods that use genetic data are areas of intense theoretical and applied research, to the extent to which, like, if there's a method that doesn't exist for a question that you want, check the literature in a couple more weeks. These studies and methods are popping up, all the time. Okay, so, I've told you, the overview and the motivation personally for me to have this topic. I'd like to give you a little bit of a introduction so I can use some of my favorite acronyms before we move forward. So, to begin at the beginning, we can talk about the genetic variant, specifically the single nucleotide polymorphism, or the SNP. And so it might surprise you that there are 3 billion base pairs in the human genome, but more than 99% of these bases are the same in all people. The one way to quantify bases that are different is the SNP, or like I said, the single nucleotide polymorphism. This is a DNA sequence variant that occurs when a nucleotide, so an A, G, C, or T, in the genome sequence is altered. So if you look on the right, you could say that this is the top is the chromosomal segment I got from my mom, and the bottom is what I got from my dad. You can see most of the places that my mom gave me a T, my dad gave me a T, and yada yada down the line. You can see that there's in the first spot and the second to the last, my mom gave me an A, my dad gave me a T, and then you can see the differences in the end. So we would call these AT SNPs and TC SNPs. So these are kind of the workhorse of what we're going to be talking about, these SNP data. Just to be a little bit more specific in our terminology, the SNP generally refers to a genetic variant that's present in more than 1% of the population. Noting that a variant can be common in one population but be rare in another, where variants are often termed single nucleotide variants. So there have been really major advances over the past 20 years in SNP measurement, or genetic variant measurement, to be a little bit more generic. So in 2003, when I was starting my PhD, the cutting edge would be measuring 30 SNPs and 3 genes. You're like, wow, this is my R01 is, this is what it's doing. Where nowadays, cutting edge is to measure or to infer 40 million variants of genome-wide. So basically all the variants in a person might have. Genetic array data remain the most common source of genetic data. So as opposed to whole genome sequencing, which tends to still be quite expensive. This is where we'll measure 500,000 to 5 million genetic variants, and then we can fill in the rest of the genetic variants with this process called imputation. So imputation, you can think about it as that the human genome is inherited in blocks. And so if you see this figure on the right, we have this ancestral chromosome that, all of these variants are inherited together. Then you have, many generations, and you can kind of see here that these would be different chromosomes across people, where the yellow would be the part that's always inherited together. So it's idea if you know a little bit of information in this yellow block, then you can guess with high accuracy the genetic variants and the that weren't measured. So imputation. Something really important to note is that the imputation might sound, it's statistically complex, requires some high level computation, but one of the things I hope I can impart today is the degree to which genetic epidemiologists and statistical geneticists funded by NIH have banded together to make resources that enable team science or science to be done by a lot of different people. One of that would be the Michigan Imputation Server. So if you have your own genotypic data, you can upload it. You can follow some quality control scripts, upload your data, and have the imputation done for you at this offsite. It's really things like this have streamlined, simplified, and really increased the accuracy of data. The other thing to think about that's so different for genotypic data than like metabolomics data or any other data is the fact that the germline genetic variants are invariant, time invariant, and we have these really well-developed imputation methods that you can basically, they enable harmonization to the degree that you don't see a lot, where basically every study that has genotypic data will have a common set of variants that are commonly annotated, that are all annotated, and with high quality. So it's the harmonization is pretty much, been figured out. So then moving on is we have our GWAS, and this is just a tool that you'll see that you can use a lot in these for causal inference in the future, which is that's a tool to develop to evaluate the genetic basis of disease. It's just as a 40,000 foot view, it's a study that surveys the genome for statistically significantly associated SNPs, and potentially some of these single nucleotide variants to the degree to which power you have statistical power. And so really what it allows you is to test 40 million variants across the genome without any prior hypotheses. So what does this look like? Well, your hypothesis is that does the distribution of a quantitative trait or the ratio of cases to controls for a categorical trait differ for a SNP? And you, so this on the bottom left is a Manhattan plot. Manhattan, because like the city, you'd think you'd have see these skyscrapers and these littler buildings. And so you have chromosome on the x-axis is ordered chromosomes 1 to 22, and then chromosome X. And on the Y is a minus log 10 of the p-value. And so wherever you see these skyscrapers or these big peaks, that's where you would see like a significant hit or loci or genetic variants that are associated with your trait of interest. The conventional multiple testing is 5 times 10 to the minus 9 or 5 times 10 to the minus 8, depending on who you ask, which is shown right here. So, again, this is another thing I can't emphasize enough, and you'll see why as this talk progresses, why this is important, that team science and data sharing are established norms in GWAS. To the extent to which when people don't want to do it, it's very strange, and a lot of policies and just expectations are in place that you share your data. This was, kind of started back in 2007 and 8, where everybody was starting to get their GWAS data and realized they didn't have enough, if they have a multiple testing threshold of 5 times 10 to the minus 8, they really need to band together and share and work together in these paper to have enough statistical power. And then so that's really developed a lot. That's motivated the development of a lot of disease-specific consortia that write these big GWAS papers. A lot of the data from which the GWAS papers are developed is available or are available on dbGaP. So that would be the raw data. And then you can imagine there's a lot of sometimes expertise that's needed to generate all that information. So a lot of the summary statistics are also publicly available on things like the HHEAR GWAS catalog. So that's one thing to, one kind of like thing you need to figure out when you use these data is where the data exist or live. You can usually assume that they live somewhere. Okay, so now that we've talked about SNPs and GWAS, so I can use my 2 favorite acronyms, we can move on to core metrics. So the first thing, if you're going to think about using genetic data in exposomics, is to make sure that there's a heritable basis of disease, right, or heritable basis of your phenotype. And so heritability, the classic description of it or is the definition is it estimates a proportion of phenotypic variation 0 to 1 attributed to additive dominance or epistatic effects. And whenever someone says that to me, my eyes cross. So really what you want to think about is this little thing called H squared. And so this is just or narrow sense heritability is another way people call it, which is just this additive genetic variance. It's basically the proportion of the phenotypic variance, that can be ascribed to genetic variance. So you can imagine if something's closer to 1, that it has really strong genetic genetic architecture has a really strong effect on the phenotype of interest. 0 means like next to none. And so heritability, I would argue, can help you gauge the potential utility of genetic data to inform the exposomic studies. And you can read some more about it, but it's also can be context specific. I can happy to answer any questions about that. So to give you an example, and this kind of blew some of my colleagues' mind, is that, we can all acknowledge that exposure to a toxic substance is probably not heritable, but its metabolism may be. So this is a paper that showed up in EHP, 13 years ago, and it was looking at the heritability or, the proportion of variance, phenotypic variance attributed to genetics, for some elements and cadmium, copper, lead, mercury, you can see here. And so they use a twin design. You don't necessarily have to use a twin design, but that's what they did. And so you can see that they're that the elements they look here are on this row, and you can see the heritability range from about 19% for arsenic to the arsenic biomarkers to, let's see here, 40% for lead. So that you can start thinking, then there's some genetic, there might be some role the genome plays in not necessarily exposure to these biomarkers, but their metabolism. Interestingly enough, then this work was followed by a GWAS, which I suspect is publicly available somewhere, and they showed that there were 8 genetic SNPs that accounted for 4 to 8% of the phenotypic variance in copper, for example, selenium, and zinc. So these are SNPs of huge effect, which you'll see why that's important. So genetic variants that really influence the metabolism of these essential elements, or toxic and essential elements. Okay, so I've shown to you why you might want to look at heritability, right? Because it doesn't make sense to look at, for example, do a GWAS or look at shirt color or something that it might not be have a strong genetic basis, and heritability can help you gauge that. So next I'll move on into the meat of the talk, which is thinking about causal inference methods and study designs that utilize genetic data. And so before we start, everybody hears these buzzy words like causal inference, but I don't ever know if it's easy to define them. So I'm going to define causal inference as the process of determining the independent actual effects of a particular phenomenon that is a component of a larger system. So you can think about that in terms of exposomics. That makes sense, right? Independent actual effects of some larger thing. And so the way I'm doing that is thinking about study designs and estimation strategies that can enable causal, to the extent possible, causal conclusions. And so in the commentary my colleagues and I wrote, we considered 6 different ways genetic data can help strengthen causal inference in exposomics. We'll focus on 2 here. It's funny, right after we published this, we keep thinking of all these other ways too. So this is just but 6 examples. The first example I'd like to talk about is evaluating reverse causation in a measured confounding. And when I was in that symposium, this is the one thing that really stood out. One of the things that really stood out to me. Ideally, I think we can mostly agree that exposomics research would leverage a longitudinal design, perspective design, that where exposures are sampled repeatedly before an outcome occurs. But you can think that's time, money. The NIH isn't wealthy. So, instead, though, a lot of exposome studies, or just population-based studies in general, use cross-sectional or case control designs. Of course, there are exceptions to case control designs like nested models or variants or case cohort variants. And so why might we be concerned about this cross-sectional design? Well, it's really the idea of temporality and the potential for effect distortion. And maybe not effect distortion, but what you estimate and what it actually represents being 2 different things. And one example I thought that was really a good example of this was this paper that showed up in JAMA many moons ago that was looking at urinary bisphenol A and metabolic disorders in NHANES. And the National Health and Nutrition Examination Survey, they were using cross-sectional data. And so what they report, I think this was their buzzy report that got them into JAMA, was that higher urinary BPA concentrations were associated with cardiovascular diagnoses. And then they have some, really significant, somewhat moderate effect, saying BPA and cardiovascular diagnoses. As a CVD epidemiologist and someone who self-reports cardiovascular diagnoses, that already makes me feel uncomfortable, let alone the cross-sectional nature. And so why might we not like this cross-sectional design? Well, the family circus has this perfect example why cross-sectional designs are challenging, right? And because the little boy's here on the plane, it's kind of like this. My husband's like this too, and he says, I wish they didn't turn on that seatbelt sign so much. Every time they do, it gets bumpy. It's the same idea with, maybe if people with diabetes or cardiovascular diagnoses, it's not that the higher urinary BPA is causing the cardiovascular diagnoses, it's that the cardiovascular diagnoses are, because they're measured at the same time, are causing people to change their diet into diet constituents that might by definition have higher urinary BPA. And you can see here that potentially 10 canned foods to avoid to reduce BPA exposure, and you can look at them here and think maybe how cardiovascular disease diagnoses might change intake. Okay, so then, one way to get around this would be, oh goodness, we're almost running out of time, would be this idea of Mendelian randomization. This is another buzzy idea, which is a popular causal inference tool that uses individual level summary data to estimate effects of potentially modifiable risk factors. And so this is where genetic data are coming into play. So, you could have your exposure X and your outcome Y. Maybe these are measured in a cross-sectional design, and you're worried about reverse causation. What happens if you're also worried about unmeasured confounding, because let's say diet or something that's really hard to measure accurately is a potentially strong confounder? Well, the idea with Mendelian randomization is instead of testing the exposure outcome association, you test the association between the genetic variance and the outcome. Because the concept behind this is if X affects Y, so if the exposure affects Y, factors also affecting X must affect Y. And so, since germline genetic variants are time invariant, right? They were defined, and then since they're time invariant, they are going to predate any measure of the outcome. Then that allows you to get have some robustness from reverse causation, and then unmeasured confounding as well, because to be a confounder, this factor has to affect the germline genetic variants. And really the only things that we can think of that would do that would be ancestry, which we can adjust for. And so here's a study I'm just going to scoot through in the interest of time that was by a friend of mine, Brandon Pierce. It's looking at arsenic metabolism efficiency. So it's not the exposure to arsenic, but it's the metabolism of it. And looking to estimate, to generate some causal inference about arsenic methylation capacity in skin lesions. And so to think about this as a start, there's a lot of been work. This is in the Strong Heart study of American Indians, looking at the heritability of these arsenic metabolites. Remember, heritability is 0 to 1. Higher is more of a genetic component to the phenotype. You can see that this is these heritability estimates are quite high, suggesting that there's a strong genetic basis to the metabolism of these arsenic species. And we can see here's our Mendelian randomization setup, where we have where maybe we've used some prior GWAS that are publicly available to identify variants that are associated with arsenic methylation capacity. And so what we do is we associate these variants with skin lesions. Again, maybe we're doing this because that the skin lesions arsenic methylation capacity information was conducted cross-sectionally. And you could think also there could be some difficult to measure unmeasured or poorly measured confounders like nutrition or adiposity. So here's Brandon's results. So these are the observational analyses, which would be the arsenic methylation capacity in skin lesions. And you see, lack of precision. It looks like this is for MMA, it's consistent with maybe a risk reducing and risk increasing effect. Not a lot of clarity here. But through the Mendelian randomization, you can see a lot more precision. And then you can see, this looks like these two lower estimates for MMA or IAS are associated really with a risk increasing effect.
I'm sorry, we're almost out of time. Are you wrap up, please?
Yep. And so then it looks like I'll wrap up. So then if you're interested, you're more than welcome to read my paper. So in general, the idea of causal inference, there's a lot more thinking that we can do. Take a look, please, if you're interested. Just noting that the application of genetic data and analytic methods will add some complexity, but this complexity and systems level thinking are core exposomic science paradigms, and genetic data only simply adds one more level of this to the complexity. So, and genetic epidemiologists in general are very used to working with a lot of cross-study collaboration. So call us if you're interested. Thank you.
Thank you so much for that talk. That was really great. And sorry, we ran out of time, and I don't know if we want to go over and ask questions, but if there are questions, then you can contact the speakers or put them in the Q&A and we'll get back to you. So thank everybody for attending today. There are a few announcements. The next webinar in the HEAR webinar series is coming up. We don't have a date yet, but it's on new technologies for chemical exposure assessments. Look out for the announcement for that and register. Here it will be in April. And then we also are, HEAR is accepting applications for the next round of analyses. And the deadline for that is March 17th. And is there one more announcement? Is that it?
Nope, that's the last one.
That's it. All right. Thank you everyone for attending today, and have a great day.